2012, treated with aortic valve replacement, ascending aortic repair. He had an FEVAR at outside institution with left hypogastric occlusion and was left with chronic dissection and a large endoleak in the infrarenal component. His cardiovascular risk factors are noted here. His evaluation consisted with laboratory tests which showed a creatinine of 1.1, echocardiogram which was normal except for mild aortic regurgitation. His pulmonary function test showed mild to moderate dysfunction, and the carotid ultrasound was widely patent with no evidence of extension. CT angiography depicts an extensive thoracoabdominal aortic dissection with a previous ascending aortic repair. As you can see in the proximal part, there is still involvement of the aortic arch by dissection and a small aneurysm. The dissection tracks across the renal mesenteric segment, the celiac axis, the SMA, two right-sided renal arteries, and a left-sided renal artery are involved by dissection. The CT angiography demonstrated here that the celiac axis originated from the true lumen of dissection, so was the SMA, the two right-sided renal arteries, and a single left-sided renal artery, and there was a large endoleak into that infrarenal aortic aneurysm. The coronal views also demonstrate that there is fairly short distance between the renal arteries and the flow divider of that infrarenal aortic device. The size of the aneurysm was 7.5 centimeters in the abdomen and 7 centimeters in the proximal thoracic aorta, and you see here a summary of the location of the renal mesenteric vessels. This patient was approached in a staged fashion with combination of vascular surgery and cardiac surgery. First, the aortic arch and aortic valve, which had regurgitation, were replaced by redo aortic valve replacement total arch using a frozen elephant trunk technique with placement of a C-tag device. The patient was then referred to me, and I performed a second stage completion thoracic endovascular repair by extending the repair to the celiac axis. We then planned a third stage repair using combination of branches for the celiac and the SMA and fenestrations for the renal arteries. This is a novel design that applies a new delivery system. It is very difficult to see, but there are preloaded wires on each one of the branches and the fenestrations. We also ordered a small bifurcated inverted limb device to extend the repair to the old infrarenal stent. The procedure was done in the GE hybrid operating room with total percutaneous technique. Note here that the approach, after percutaneous approach is established, axis was established in the right femoral artery and in the left brachial axis. A wire was advanced to the thoracic aorta. Through the left femoral approach, we advanced a snare, and this portion of the video demonstrates snaring of the left brachial wire, establishing left brachial to femoral wire. Next, the fusion imaging is calibrated by selective catheterization of the left renal artery. Note here that the catheter is perfectly placed in the middle of that purple ring that locates the ostia of the left renal artery. Once the vessels are located, a 12-French flexor sheath was then introduced via the left brachial approach and positioned in the mid part of the thoracic aorta. The device was then oriented extracorporally. Note here that the device has a very long delivery system. That delivery system is a 20-French sheath that leads to a 7-French sheath that will exit from the femoral approach through the left brachial approach. The sheath is now being introduced first with the smaller 7-French sheath, then leading to the 20-French sheath, all the way to the location of the target vessels. The sheath is now exit via the brachial approach as depicted in the top part of the video. That sheath has inside 4 preloaded wires. These wires allow immediate access to each one of the vessels. In this segment of the video, you see a sheath being advanced into the celiac branch, and using the assistance of the fusion, a catheter is advanced to the celiac axis. This is confirmed with a limited angiography, and a 0.014 wire is then advanced and positioned deep in the splenic artery. Next, the attention is directed to the superior mesenteric artery. Using digital zoom, you can see in collimation, limiting the radiation, the SMA is catheterized, followed now by catheterization of the left main renal artery. After a wire and catheter advance to the left main renal artery, this is exchanged for a Rosen wire. And finally, the right lowest main renal artery is selectively catheterized. At this point, I elected to position a sheath and a stent ready to deploy in the right renal artery, and elected to not catheterize the accessory small renal artery that was just above. The device was then fully deployed. The delivery system was removed and the landing zones were dilated using a compliable coda balloon. Next, the repair was extended distally into the old stent by using a small bifurcated device with an inverted limb. Note how important it is to have adequate imaging and precise locations so that you don't crush the renal stents, which are not yet deployed at this stage. During this segment of the procedure, the gate is catheterized, the repair is extended, and then flow is restored to the lower extremities and the femoral arteries are closed. The entire remaining part of the procedure is now done from the brachial approach, with flow restored to the legs. First, the right renal stent is deployed. You see here it's being flared with a balloon. And note that this is a fluoro loop and not a digital angiography to limit the amount of radiation. Next, the left renal stent is then positioned, a puff angiography is performed, the stent is deployed and again flared using steps identical to the right side. After each one of these stents is deployed, the respective wire is then removed to allow more space within the 12-French brachial sheath. In this segment of the video, attention is then directed to the accessory branch, which was cannulated with a .014 wire and stented using a very small coronary stent. Note that this part of the aorta was sealed by the dissection. We then direct our attention to the SMA, which was stented, and finally, the celiac axis is now stented with a fluency stent. The patient also had a hepatic artery aneurysm, which I elected to leave untreated at this point. The repair was completed with diluted contrast with arch and thoracoabdominal aortography. We then performed a cone beam non-contrast CT of the renal mesenteric segment and observed that the celiac stent was crushed by the dissection and the median arcuate ligament. We also noted some compression of the SMA stents. The remaining renal stents were adequately expanded without any technical problems. We then obtained access again from the left approach and reinforced both the SMA stent depicted here, followed by the celiac stent. A cone beam CT was then repeated with significant improvement in the technical result. Again, this problem would not have been detected by only a completion angiography. This is the follow-up dismissal CT demonstrating adequate expansion of the stents with no evidence of attachment leak, but with a type 2 endoleak originating from a number of intercostal arteries already there in the distal part of the thoracic aorta. I think this case exemplifies the complexity of fenestrated and branch endovascular repair in the current era with the available technology, and also the options to treat patients with difficult thoracoabdominal aortic dissections in a staged fashion. This patient had total aortic repair, including the arch and the entire length of the thoracoabdominal aorta. The patient progressed well, with a total hospital stay of 6 days, no neurological deficits, and a normal creatinine. So the 10 tips that I would say that I would like to highlight is patient selection, learn to say no, select your proper landing zone, don't compromise your repair, design wisely, use to your advantage catheters, tapers, guides, branches, combinations of fenestrated branches, minimize contrast. Very importantly, minimize radiation exposure. Optimize your imaging and try to work on a dedicated hybrid room with fixed imaging. Know your bailout maneuvers. Conversion to open surgery is not an option on these complex cases. Use endovascular finesse, avoid leg ischemia, minimize blood loss, and assess your result immediately using cone-beam CT. Thank you very much. I'll be open to questions.